All of you are requested to turn off your mics. Right. Okay, so I think we have enough people over here. Should we start? Right. Okay, so yeah, in today's session, we are going to discuss decision making capacity, informed consent, this its components, end of life care, and all the things about that as well. So we're starting right away. This is a question: do we need a psychiatrist to decide if a patient has decision making capacity? You can answer the question in the chat box, and then we'll discuss it. Okay, someone says no. Okay, someone says yes, I guess. So the point in this thing is that that these decisions depend on the situation. If it's a simple case, the patient has some condition, let's say even a psychiatric condition, and you as a physician is able enough to understand the situation and to figure out if the patient has decision making capacity based on the functional status of the patient. We did discuss this, the difference between competence and decision making capacity. So if you as a physician think that you're able to make the decision, then you do not need to consult a psychiatrist. However, if it's a condition which is in which you're not sure about the situation, or if you think you need consultation, then you definitely should consult a psychiatrist to for them to let you know if the patient has decision making capacity. So ideally, in an exam question, you 95% of the cases you'll go for the answer which says the physician himself or herself would make the decision, unless and until they make it clear to you in the question stem that the scenario is very confusing and the physician is not able to interpret and it's equivocal. Then you will refer the patient to psychiatrist, and the psychiatrist, or you'll call the psychiatrist to the emergency room if that's emergency condition, and then you'll decide if the patient is in the functional status to make decisions. Okay, so I hope you got the answer to this. The next one is, what is emancipation versus partial emancipation? So about this, it's kind of a simple concept. Partial emancipation, I'll go for partial emancipation first. Partial emancipation is something in which both of these conditions apply to minors. So we discussed earlier that minors, anyone who is lesser than 18 years of age is considered as a minor. So partial emancipation, if the minor is seeking care for, let's say, about contraception, about sexually transmitted diseases, about prenatal care, about substance abuse, about conditions like, let's say, gonorrhea, chlamydia, HIV. So any sexually transmitted disease or anything about contraception, anything that you think if you discuss with the parents will kind of break the physician patient relationship, your relationship with the minor in that situation, you should not you should not you should not inform the patients in those conditions. This is partial emancipation. This is for minors who are not independent in living their lives. Complete emancipation or emancipation, it goes for minors who are independently living, and that includes any married minor, any minor who is self-supporting, who is living independently, or who is in the military, or maybe a parent of a child, and he or she is supporting his or her child. So in this condition, the general theme is that the minor should not be dependent on his or her parents. If they are not dependent financially on their parents, then they are completely emancipated. They are completely emancipated. So if they are living independently, if they're self-supporting, they're married, they're in the military. This is important. If they are in the military, then right, or if they are parent of a child that they are supporting, right? So but in what situation you will still need consultation with parents? Only the situations which are complex. For example, anything about organ donation, anything about abortion, anything about let's say any complex case that involves a very significant surgery. In such situations, you will not look at if the patient is partially emancipated or emancipated. You will have to consult either the parents or the court to decide what we should do in such situation. So I hope you got the difference between partial emancipation and complete emancipation, right? Partial emancipation is just in certain situations for minors who are not independent. But if the minor is independent, regardless of the situation, this is important. Regardless of, it's not just that if they are independent, they can make any decision, not just sexually transmitted diseases or contraception. They can make any decision by themselves without having to consult their parents if they are financially independent. Okay, this question. We come to informed consent now. Can neighbors, aunts, uncles, and grandparents give consent for treatment of a minor? What do you guys think? Okay, Dr. M says no. So, if parents are not okay present, okay, okay, depends. Yeah, this is important. It depends, but even if this is important, I wanted to highlight this point. Even if the parents are not there, let's say it's the aunt, it's an uncle, it's a grandparent, they cannot make decision for the child, even if the parent is not there, unless and until they are legally appointed by the court to be the guardian of that minor. This is important. If there is no parent, then aunt, uncle, neighbor, friend, here and there, anything, it doesn't matter. It doesn't matter. It's either parents or it's either the court that decides who will decide for the patient what happens to the patient. But do remember in mind that it doesn't apply for emergency situations. Emergency is implied consent. Emergency is implied consent. What do we mean by implied consent? If a patient is coming to us in the emergency department and the patient cannot make decisions, it means that if they came to the emergency department, they're implying that they need treatment and they are allowing you to treat them, right? So but in non-emergency situation, you ask the parents, what do the parents want, right? But if it's a condition in which if you do not treat the child and the child will die, if it's a risk to the life of the patient, of the minor, in such situation, we did discuss this, the patients cannot refuse treatment. But if it's a situation where it's either let's say it's a condition. If the parents say do not treat the patient, let's say for example the patient has flu and you're prescribing let's say acetaminophen or aspirin or something like that, and patients say do not treat the child, and if you do not give the drug, the patient will not die. In such situations, you can go with what the parents say. You can go with that. And also in situations where death is inevitable. For example, a patient has severe neurologic brain hemorrhage or some damage or anything like bleeding, such that the BP is really, really, really low, and you're certain that the patient is going to die. In such situations, now it's just about the comfort. Do you want the patient to die in comfort, or do you want the patient to suffer and die, whatever the patient is, the situation the patient is in? So in such a situation, if the parents, whatever the parents want, we'll do that only in a situation in which the patient is in a condition in which, let's say it's a cancer, and you think that you can give chemotherapy and the patient will survive, but if you do not treat, the patient is going to die because of metastasis, and the patients disagree, you are not going to go with decision of the parents, right? This is important. So I hope you got the point behind this concept, right? This question: Can a parent refuse therapy for children who are severely disabled or has severe neurologic dysfunction or intellectual disability? Share the answer in the chat box. Okay. Dr. Noman says if they refuse take court orders. Akib says no. Um, Dr. M says yes. So conflicting answers. Um, so in such situation, the bigger picture is the parents cannot refuse therapy, even if the child is severely in a condition which let's say damages the brain. When I was talking about the brain hemorrhage or something, it was about death. It was about the child was going to die, right? So in such situations patients can refuse treatment, right? Like you want the patient to die in peace, patients parents say no, we do not want to further. They think that if you treat the patient more it will further cause damage and will make the patient suffer. In such situations you'll go with what the parents say. But if it's a condition like what I stated in this question, who are severely disabled, disability would be, let's say an intellectual disability, any syndromes, like let's say Sturge-Weber syndrome, or let's say tuberous sclerosis, or anything, let's say Down syndrome. In such situations parents cannot refuse therapy. Parents cannot. And this is important. This is in simple words, in a society you do not differentiate people on the basis of their syndromes or their diseases or their neurologic dysfunction. Any minor with any neurologic deficit is considered just another minor, right? So in such situations we'll go with what is best for the patient in that situation, even if the parents refuse. And this is important. Ideally you will inform the parent, you will take permission from them. However, taking permission is not synonymous with, if they refuse we will not go with treatment. We are going to treat the patient anyways. However, like considering medical ethics, we'll have to inform the parents, just to inform them. Not if they refuse we'll still go with treatment, but we'll have to inform them ethically, right? So I hope you guys got the point behind this, right? So the only times parents are allowed to refuse care for their child, if they're like that, if death is inevitable, then the parents can refuse treatment. Okay. Can a psychiatric patient make informed decision? Mm-hmm. Anybody? Okay. Dr. Ahmed says yes. Gulmina says yes. Okay, so let me give you a scenario. A 25-year-old patient with schizophrenia comes with acute stage of let's say the patient is throwing tables around and the patient is angry, and you ask the patient what's the time, and the patient doesn't know the time, the patient doesn't know where he or she is, and they're just blabbering and saying whatever, you do not understand what they're saying. And you as a physician think that the patient needs antipsychotic, let's say haloperidol, and the patient says no, I don't want the treatment. So what do? Do you treat, do you give the drug, or do you not give the drug? Okay, Dr. Javed says no. Dr. Rahman says give. So why do you think we should give it? What's the reason? What's the reason? It could harm others. Is that the reason? Is that the reason? Okay, there is no one in the room and the patient cannot harm you, the patient is restrained. So would you treat or would you not? Okay. Okay, to control aggressive symptoms, but why do you want to control the aggressive symptoms? Like, is it because the patient is aggressive, or is it because you as a physician think that that is the best course of treatment for this patient in this situation? Dr. Ahmad says he can't decide himself. Yeah, this is the answer. This is the answer. In such a situation, you do not see the psychiatric aspect of the patient or the neurologic dysfunction of the patient. As long as the court hasn't said anything that they're legally incompetent, if the court has said declared that they are incompetent, then they'll have appointed someone as a guardian. But if the court says the patient is competent, and now the patient comes to you, regardless of what the patient's condition is, bipolar disorder, schizophrenia, whatever, if the patient is in an acute stage of delirium or something that would functionally disable the patient to make informed decision, then you will do whatever you as a physician think. This is the reason. Not because the patient will harm anybody, or because to control his anger or something, but because you as a physician think that this is what I think is the best course of treatment for this patient, and the patient is not able to make his decision at this moment. But if the patient is not in acute stage of delirium or something that would hamper his functional status to make a decision, informed decision, then in such a situation you let the patient declare whatever they want to do, right? So this is an important concept as well. Next is, this is a quick question. A patient needs colon cancer screening. You guide him about colonoscopy, explained risks and benefits, and also explained the risk if patient does not undergo screening, right? So for colon cancer, the we I as a physician think that that colonoscopy is the screening method. I explained the risks and benefits. This is the risk. If you do this, maybe you can get injury to the colon. You can get this. You can get this. Infection can occur. Benefits would be that we can detect your cancer earlier. We can treat it early. I also explained the risks if the patient does not undergo the colonoscopy. Like, let's say I told the patient you can have a cancer and we can miss it if you do not want to go with colonoscopy. So the patient says, okay, I agree, do the colonoscopy for me. During the procedure, what happened was that I accidentally perforated his colon, right? So in this situation, am I liable or am I not liable? Can if the patient later sues me, is am I liable to the in this situation or not? Would I be held accountable? I'll wait for 5 more seconds. Okay. No, no, no. So the answer is yes, I will be held accountable. What do you think could be the reason? Even though I explained the risks, the benefits, uh, but do you think there are certain components of informed decision that you do not know, and you have to? Yeah, one person said yes, liable. So what do you think is is the reason? Dr. Ahmad says the physician is liable. Why? Yeah, think about it. Think about it. So the answer is, you know, there are certain components of informed decision. Let me go to the next slide, and you'll know that. Skip the first question. Go to the second one. What are the components of informed decision? So the components of informed decision are number one, whatever procedure you're doing, you'll have to explain to the patient the risks and the benefits of that. Number two, you'll explain to the patient what will happen if the patient decides to not undergo the treatment or the procedure. Number three, what are the adverse effects that can occur because of the procedure that you're suggesting? And number four, what are the alternatives that the patient can take? What are the alternatives that the patient can take? In this situation, we explained the patient the risks and benefits. We explained that the patient will have problems if we do not undergo the screening. We explained the we also explained this adverse effect part of it, what problems can occur because of it. But we missed one thing, the alternatives. So for colon cancer screening, there are certain modalities, like we can do colonoscopy, we can do CT colonography, we can do capsule endoscopy, we can do flexible sigmoidoscopy, or there are stool tests which are not invasive, like we can do FIT, which is done annually, which is known as fecal immunochemical testing, or we can do fecal occult blood testing. So let's say the patient will say, why didn't you tell me that I could also have done fecal immunochemical testing, just using antibodies to detect occult bleeding in my GI tract? So why did you put me through a colonoscopy? So in such a situation, you are liable because you didn't explain the alternatives. Is important. In an informed decision, you have to take care of all the components of the informed decision, specifically the risks and benefits, the adverse effects, what will happen if the patient refuses treatment, and also what are the alternatives. What are the alternatives? So if there is a question, who can get the informed consent? Let's say, let me give you a situation. You're a surgeon, you're a colorectal surgeon, you have adequate expertise in the field, and your colleague is to undergo a surgery, but he is late and he is on the way, and he calls you, if you can, if my surgery starts at 10 o'clock and I'm running short of time, could you please get consent from the patient? Could you get consent from the patient? And once I reach, the consent will have been signed, I'll just go and undergo the surgery. What do you think should you do in such a situation? Mm-hmm. Can you go and take consent from the patient? Okay. Dr. Khan says no. Why? Okay. Dr. Ahmed says if you know everything about the procedure, yes, go take it. Dr. Yamna says the doctor performing the procedure should take consent. This is the answer. This is the answer. This is the answer. So even though you have expertise in the field and you know the risks and benefits, alternatives, every single thing that is involved in the components of informed consent. However, the ideal situation is the person who is doing the surgery, they are to get the informed consent from the patient. This is important. So any person who is doing the surgery or whatever procedure, they should take the informed consent. Okay. So remember this as well. Quick question: patient undergoes laparotomy for abdominal aortic aneurysm rupture. You find a liver carcinoma. During the surgery you found that there is a big liver and it's an end stage disease. So as a physician, the best treatment is to remove the liver. But what do you do in such a situation? The patient came for surgery, and either the patient or the surrogate decision maker or healthcare proxy, they consented to the repair of the ruptured aneurysm. But during the laparotomy you found out that the liver is carcinomatous. What do you do? Mm-hmm. Okay. So take consent from immediate relatives, parents, spouse. Okay. There is spouse with the patient as well, and she says, yeah, I would like the liver to be removed because that could kill the patient. What do you do? Dr. Yamna says inform the patient about the surgery, the surgery about cancer and further plan. Oh yes, do it, remove. Dr. Ahmed says. So the answer is you do not remove it. Every single procedure needs informed consent. Every single procedure needs informed consent. This is very, very, very important. So let's say you're doing a surgery on the right hand of a patient, and it's for some vessel repair, but during the surgery you found a cyst, or you found something, maybe cancer of the bone, let's say osteosarcoma. In such a situation, even though you think the best treatment is a surgery, and in whatever situation, if I close the patient and I ask and the patient consents, I will have to reopen and do the surgery again, go for a surgery again, but do not do something that is not ethically allowed. Okay. So this is something where non-malfeasance and beneficence conflicts with ethical principles, but this is a principle. You every like informed consent is required for every single procedure, right? So every new procedure you do, you have to take consent. You close the patient, the patient gets out of anesthesia, the patient gets mentally in the mental status to give you decision, then go for surgery. What if the patient says, do not do surgery, I do not want it to be removed, and you had already removed it, you'll be in a bad situation. So you have to take consent for every procedure. The next question is, beneficence sufficient to eliminate the need for consent? For example for example um, a patient comes to me, and the patient is unconscious. The patient is unconscious, and the patient needs some treatment. Although the patient is not going to die from that thing, but the patient is not in the situation, or let's say the patient is not competent and the guardian is not present, and in the situation you think that a certain procedure is in the best interest of the patient, but the patient is not able to consent and the guardian is not there. So would you go with the surgery or the procedure, or would you not? Okay. Dr. Ahmed says no, don't do it. I think wait for the guardian. Okay. Yeah. So actually in such a situation, yeah, Dr. Ahmad says no. So in such a situation, you look at the case. If it's an emergency situation and the patient will die, so that's implied consent, go with the procedure. But if it's non-emergent condition and it's not very urgent, then beneficence is not sufficient to eliminate the need for consent. Beneficence is, you think this is in the best interest of the patient, but you have to take consent from the patient. You cannot totally eliminate that component of ethics, so you have to take consent from the patient. Quick question: patient had consented against blood transfusion even if necessary. Patient says, you will not transfuse blood to me, right? And now patient, after a few days, a patient gets into trouble and needs transfusion. Patient is unconscious, cannot give decision, and family member says to transfuse. What do? The patient is unconscious, cannot make decision, patient needs blood, and family member says to go with it. Do you transfuse or do you not? Mm-hmm. Okay, Dr. Ahmed says no. Mm-hmm. Almina says no, don't. But if that situation, then transfuse. Mm-hmm. Okay. So Dr. Shabir Ahmed, if the patient will die if you do not transfuse, and family member as well consents that okay, yeah, go with transfusion because the patient will die, will you transfuse? The patient will die if you do not. So yes or no? Yeah, no, because the patients what the patient wanted, he or she had made it clear. Now the patient got into a situation where the patient, the you follow the patient's last wish. You follow the patient's last wish. The last time the patient was conscious and able to make decision, whatever the patient said at that time, you follow that. So now, even if the patient needs transfusion, and the patient is going to die if you do not transfuse, the patient had already told you, I do not want transfusion in any situation, even if necessary. So, is oral consent uh, is oral consent acceptable? Okay, depends on procedure. So let's say patient, it's an 86-year-old patient with amyotrophic lateral sclerosis. The patient cannot talk, but the patient needs percutaneous tube, gastrostomy tube for nutrition. What do? The patient cannot talk. The patient cannot write. The patient cannot write. the patient can like nod or like give some expression if you explain to him, but the patient cannot write, muscles are not working properly. What do you do then? Do you ask someone else to consent for the patient, or do you go with what you think as a physician is best, or do you get whatever consent is possible in that situation? Mm-hmm. Okay, so in such a situation, you go with, yeah, do whatever consent is possible. This is the right answer. If emergency, then whatever. No, it's not even about emergency. In whatever situation, let's say the patient needs that thing. The patient needs that thing, and let's say this is a patient who needs a cardiac, a PCI procedure, percutaneous coronary intervention. The patient had a STEMI, and the patient is not in the situation to write and read the whole consent form and sign it for you, and maybe you can quickly go over the risks and benefits of the procedure and tell the patient, okay, this is the risk, this is the benefit, this is the adverse effect, this is the alternative, and we think PCI is the best treatment. So can the patient just orally say yes? Yeah. So ideally in such a situation, even if it's not emergency, you can go with an oral consent if the patient is not in a situation to write. If the hands are not working, what do you do then? So in such a situation, ideally, the only thing you should consider as a physician, you should have someone who is a witness. If something happens later on, and some trouble happens and you're held liable, then at least you're able to prove that the patient orally had consented. So in such a situation, you should have someone who is a witness to the oral consent. Okay, so consent on telephone, is it acceptable? Mm-hmm. Is it acceptable? Dr. Shabir Ahmed says no. Yes, after confirming the parents. Okay, it's not the parent, let's say, and the patient has a surrogate decision maker, healthcare proxy, and you cannot inform the patient. The patient is in a condition in which you cannot talk to the patient. The patient cannot talk to you, and you got a phone call. You got a phone call from the healthcare proxy telling you to go with the treatment and a specific treatment, and they are on the telephone. Would you go with that or would you not? Yes, no. Go with it. Okay. Dr. Square says yes. Okay. Dr. Shabir Ahmed says yes. Okay. So yeah, yeah, you can go with it. In such a situation, the main thing you have to consider is number one, whatever the person is saying, is it what the patient would have wanted? Like in any condition where you're taking consent. Number two, the person you're speaking to, you have to confirm if they are the healthcare proxy or the surrogate. So is it something that match with the records? You ask them the name, the details, date of birth, the name of the patient, their name, all the records. Once you're confirmed that it's the right person, then. And number three, you should have a witness. You should have a witness with you who can later on consent that, yeah, this person had consented over a telephone, over, let's say, the surrogate decision maker, healthcare proxy, or whatever. So you have to just consider this thing. Next question: 37-year-old pregnant woman needs transfusion and she refuses, but husband says to transfuse as child's health is in danger. What do you do? Transfuse or no? Okay. Dr. Shabir Ahmed says child's health is in danger. Transfuse. Is it a child or is it a fetus? I'll call it a fetus. Nope. Okay. And why so? Why so? Hmm. Okay, yeah. So the point is a fetus is not a person. A fetus is not a person unless and until the fetus is out of the womb, regardless of the weeks of gestation, 34, 37, 40, whatever. If they're inside the womb, they're not a person. They're not a person. The mother is the person, and it's the mother's head whatever she wants to do with her body, right? So as long as the fetus is inside the womb, regardless of the weeks of gestation, the mother is it's the mother's body. The fetus is part of the mother's body. You go with what the mother wants. But yeah, ethics is hitting you hard. This is important. This is important. A child is only considered a child, a human being, a person once they are out of the womb, even if it's 20 week of gestation. But in this situation, the mother refused transfusion. It's not the father's say over here. You do not even think about the pregnancy part of it. Just think about a normal person, a normal non-pregnant person making her own decisions. Unless and until the child is born, we are not considering that. So the mother's rights is to be considered. Father has no legal right over here. Okay, so important. We come to at end of life issues. This is our last topic for today. What are your thoughts on substituted judgment? Let's say a person who has severe neurologic dysfunction, and they're not competent to make their decisions. What do you do in such situation? What is substituted judgment? Okay, yeah. What's that? So substituted judgment is something when a patient is not either in the mental status to make decisions, is functionally not stable, not does not have decision making capacity, or okay, someone says ask the spouse, could be but not necessarily. So they do not have decision making capacity, or they are not legally competent because of their neurological dysfunction, because of maybe because they are a minor. They are not legally competent as well unless and until they are 18 years of age. So in such situations, you go with the healthcare proxy, which the court has legalized, or the durable power of attorney, or the advance directive, or a living will. Or you ask, or this is actually making a judgment that is substituted for the patient's judgment. Let's say the patient cannot make decision now for whatever reason. What do you think as a physician should happen? But in such situations, you have to go with either the legal guardian, or with the healthcare proxy, or durable power of attorney. So my question from you guys is, when do you go with the guardian? When do you go with the healthcare proxy? When do you go with a family member? What is the difference between them? What is advance directive? What is healthcare proxy? What is living will? What is the difference? What is surrogate decision maker? What is durable power of attorney? What is a living will? We have a lot of terms, right? So this is what we will talk about. So advance directive is actually, it's like a method by which a patient communicates his wishes for his health care in advance of becoming unable to make decisions for himself, right? So I'm sorry. So let's say the patient is in the mental the patient is able to make decisions today. So what you do is, you ask the patient and you decide with them their advanced directive for the time in future in which they will not be able to make their decisions, right? So what are the components of advanced directive? Number one is the healthcare proxy, or the medical power of attorney, or the medical proxy. The name, as the name says, a proxy is someone, you're not present there, you cannot make decision, someone else is making decision for you. But a healthier proxy is someone whom the patient himself or herself declares as their substitute, as their proxy, for the time when they are not able to make their decisions themselves. This is a healthcare proxy. This is also known as durable power of attorney or medical power of attorney. Why do we call it durable? By calling it durable, we mean that this persists even after the patient loses decision making capacity. So for the whole life of the patient, this person is now responsible for making decisions for that patient. Legally this person can do that. This is a durable power of attorney. This is durable, it will sustain. It's not like the patient has lost health, now we cannot make this person cannot make decision for this patient. In whatever situation, end of life care, organ donation, anything, this person can make decisions for this person. Okay. What is a living will? A living will is a written document. It is a document which the patient writes for you. I do not want a resuscitation, I do not want intubation, I do not want blood transfusion, I do not want this, I do not want this, I want this. Let's say if I need ventilation, you can go to this extent, you cannot do this, but you can do this. This is a living will. It is a documented thing. It is a documented thing in which the patient expresses to you what the patient would want in certain situation. It's not a human being. It's not a human being. It's a documented form. So which one of these do you think is better or more flexible? Healthcare proxy or living will? The session will end at 9:30 to 9:40. This is our last few topics. Okay, which one do you think is more flexible? Healthcare proxy or living will? Okay, so let me answer this. What do you think? In a living will, can you write every single condition, every single therapy you will need, and every single concern? I want this but I do not want this. I need 5 ml blood but not 100 ml. I want this but not. It's like a written document. It's like a written document which the patient is a whole person, a human being who decides for the patient. So this is a normal human being, and they can think about, let's say if something pops up that is not present in the living will, what you'll do is go to the healthcare proxy and explain to them, okay, this is number one option, this is number two option. So what should we do then? What do you think the patient would have wanted? The only things that they must consider is and what the patient would have wanted if he or she had the capacity. This is the only important thing that they have to take care of. Other than that, they can make their decisions. So the more flexible thing is a healthcare proxy, because you cannot put every detail in a living will. Another thing is surrogate decision maker. What is the difference between healthcare proxy and a surrogate decision maker? Okay. Okay. So a surrogate decision maker is different from a healthcare proxy in regards that healthcare proxy is someone whom the court appoints as a person to make decisions for the patient. The patient is not in the mental capacity to make the decision or not legally competent. But a surrogate decision maker is someone whom you improvise over there in the hospital. Let's say let's say there is no healthcare proxy, there is no living will. In such a situation, what you do is, there are family members, so you ask them, what should we do in such a situation? You do not make your own independent decision. You can give them your medical judgment, your suggestions, explain them the conditions so that they can make an informed decision. However, it's up to the family. So in such a situation, the surrogate decision makers are the family members, and there is a hierarchy for that. The first person who can make the decision is the spouse of the patient, right? The spouse of the patient. Then we can go for the children of the patient. Adult children of the patient. then we go for the siblings, and then for any friends who know the patient closely, right? So this is this is surrogate decision maker: spouse, then parents, then adult children, then siblings, and then friends. This is the surrogate decision maker. So let me give you a situation in which let's say let's say the wife says something, spouse says something, daughter says something, the other person says something. What do you do in such a situation? They give you suggestions, or they say stuff which is contradictory. What do you do then? Okay, do you follow the hierarchy? Okay, so ideally, what you should do is you should have a family meeting. This is a good USMLE perspective on this. On the exam question, if there is an option which says conduct a family meeting, make them sit together, discuss with them, let them get to a mutual consensus. This is what you go for. This is what you go for. But you did a family meeting, and still they're not agreeing. Then in such a situation, if the spouse is there, you go with their decision. If spouse is not there, and adult children of parents are there, but let's say mother is saying something, father is saying another thing, what do you do then? In such a situation, make them sit together, conduct a family meeting. The physician should be there, then give them time to think about it, decide. If it's not an emergent situation, if emergent, go with what's the best treatment. If not emergent, you let them decide. If they can still, let's say parents are not there, spouse is not there, or they're not or they're dead or something, and the children are there, but they are not mutually agreeing on something. What you'll do in such a situation is conduct a family meeting. If they still do not agree, what do you do? what do you do You conducted a family meeting, daughter is saying go with this, son is saying go with this, another son pops up and he says I've been living with my dad for over 30 years, I'm the one whose judgment and whose decision should be valued over the others. What do you do Spouse is not there, parents are not there, the only people who are there are the children of the patient. I need a quick answer. Okay, children are not agreeing. You conducted a family meeting, still not agreeing. Where are all the other people? I need answers. Anybody? Anybody? Okay. Okay. So in such a situation, the next best thing to do would be to go and consult ethics committee, or a court order, or a court. Take it to the court. Yeah, take it to the court. But before a court, good answer is ethics committee. The ethics committee is something that does such stuff. So if they're not agreeing on a certain treatment, then you consult the ethics committee, and they have to agree on they have to make consider what the physician thinks, what the children think is best, what the patient would have wanted, and then they make decision for the patient. So this was our session for today, and what we discussed was some aspects of informed decision, partial versus complete emancipation. Muiz, if you have something to say.
Yeah, hello everybody. This is Moise. I hope you guys have learned something, if not everything. I think it was a great learning session and you guys have enjoyed it. I will try to summarize it, not explain, because Walid has done a great job explaining each and every terminology. I will just try to make a general approach for you guys. It's not an authentic approach. It's just that I've tried to make it simple for you guys, like how to approach a case. Okay. So suppose a patient comes in, what do you look for? You look for if he's a minor or not. You check if he's a minor or not. Suppose he's a minor. And what is minor? If he's less than 18 years old. All right. If he's a minor, then you look for if the situation is of life saving situation, like if he it's an emergency situation, either he needs a blood transfusion or a surgery or whatever, then you just go for it. You don't need any parental consent. Okay. If it's not a life saving situations, you just wait for a legal guardian or a parent. All right. If it's not emergency situation, then you also look for a case if it's an emancipation or partial emancipation. Okay. So a patient walks in, you look for if he's a minor or not. If he's a minor, you look if it's an emergency situation or not. If it's an emergency situation, just go for it. Don't ask for parental consent. All right. And if it's a case of emancipation or partial emancipation, then go for it. You don't need any consent from parents or any other legal guardian. All right. Now, if he's not a minor, an adult walks in, then you check for legal competency if he's a competent or not. And competency is decided by the court. All right. Walid has mentioned it in the first session. The difference between competency and decision making capacity has been cleared by the Walid in the first session. So you check for competency. If he's competent, if he's not competent, then there must be a person assigned by the court as a guardian for that person. You should ask that person on behalf of the patient. If he's not competent, you should ask the person assigned by the court on behalf of that person. Okay. If he's competent, then you have to check for decision making capacity. As Walid mentioned, every physician can assess for decision making capacity. Psychiatrists are not like it's not a criteria. Okay. Then what do? If the physician, if you are a physician and you assess for a decision making capacity and he has the capacity, then you proceed with the basic approach, like explain the risks of the procedures, the benefits, the alternatives, and if he doesn't undergo the procedure, what might happen. Okay. Walid has explained it. Now, if he hasn't now, if he's unconscious, for example, the patient is unconscious and he doesn't have decision making capacity. All right. Then what do? You look for an advanced directives. You look for advanced directives. What are the advanced directives? Healthcare proxy, living will, and also surrogate decision maker. But healthcare proxy is the superior and living will is the superior things. Then you look for surrogate. For example, a person walks in and he says that I'm healthcare proxy. You look for the documents he has which provides the evidence that he's a healthcare proxy. Then you don't hear a spouse or anybody in his family, not even his kids or his parents or anybody. It's the healthcare proxy who's going to decide what should we do. All right. Then the surrogate, Walid has really explained really good the hierarchy. And if there is a conflict, then you guys call a meeting, family meeting, or call ethics committee, or go straight to a court. Okay. Now he doesn't have advanced directives, nobody, then you should also go to the ethics committee and decides for the patient. So मैं सिर्फ एक जनरल स्केच बना रहा था कि अगर पेशेंट आए तो आप क्या करेंगे. I will repeat very quickly कि अगर पेशेंट आए तो आप सिर्फ देखें कि if he is a minor or not. अगर वो minor है, I will suggest you guys कि ये थोड़ा सा ये स्केच बना ले अपने लिए. It's really important. It's not authentic sketch, I will repeat, but it will help you guys ना कि proper वो आपके पास. A patient आया, आप लोगों ने चेक किया कि if he's a minor or not. अगर वो minor है तो check for if it's an emergency situation. अगर emergency situation है, then you don't need any consent. Just go with the procedure. Okay. अगर emergency situation नहीं है, for example, then you wait for the guardian. Obviously, you don't do anything. All right. फिर आपने चेक ये भी करना है माइनर के केस में कि अगर वो emancipated या partially emancipated का केस तो नहीं है. सही है. That's the minor case. Now if an adult walks in, आपको चेक करना है कि either he is a competent or not. अगर वो competent नहीं है तो कोर्ट जनरली इस तरह पेशेंट्स के लिए फिर असाइन, वो लोग असाइन करते हैं इस तरह गार्डियन, फिर आपने उनसे कंसेंट लेना है. सही है. देन अगर वो कॉम्पिटेंट है, फिर डिसीजन मेकिंग कैपेसिटी चेक करनी है उसकी, वो जनरल फिजिशियन करता है. अगर वो है तो फिर आपने एक्सप्लेन करना है सारे प्रोसीजर्स के, रिस्क को, बेनिफिट्स को, अल्टरनेटिव्स को. और अगर वो प्रोसीजर ना करे तो क्या हो सकता है. सही है. और अगर उसके बावजूद भी अगर वो कहे कि मैं नहीं चाहता ये प्रोसीजर, then don't do it. It's the patient wills to decide. All right. फिर अगर उसकी डिसीजन मेकिंग कैपेसिटी नहीं है, वो अनकॉन्शियस है, फॉर एग्जांपल, देन लुक फॉर द एडवांस डायरेक्टिव्स which is healthcare proxy, living will, or surrogate decision maker. As Walid has written in the comment section, healthcare proxy is greater than anybody. Okay, than anybody. Living will and healthcare proxy का difference Walid ने clear कर दिया है. फिर surrogate में वो hierarchy, and then if he doesn't have any advanced directives, calls the ethics committee and let them decide what's the best for the patient. Okay, so this was a general approach. I think it was a great yeah, I will try to share it with you guys. Okay, I will try to write it neatly, and then I will try to share it with you guys.
Yeah. So what
Right.
we can do is make an algorithm and then we'll share with you guys. Or
Yeah,
if
yeah,
someone has question, you put either in the chat box or in the group.
yeah.
We'll discuss that
You
in
can
the
ask
future.
questions or
Yeah.
anything. I think it was a great session. Walid has done an amazing job to explain all these things quite beautifully.
Yeah.
Even I have learned a lot of things from him. So I think it was a great session,
Yeah.
and I hope you guys.
As a general disclosure, this presentation was made in collaboration with Muiz. So most of the red I got from him, but then his kindness allowed me to present it. So thank you for that, and let's hope for better future collaboration. We look forward to really good sessions in the future as well, inshallah. So
Inshallah.
if Muiz, just do you have to say anything else?
No, I think I'm done,
All right.
and
All right.
I think that's it.
All right. Thank you so much and see you next time. Good luck. Goodbye.
Goodbye.